Hello everyone, my name is Ruijing Xin. My mentor is Professor Xihai. It is my great honor to participate in the discussion, and the topic I want to discuss is risk factors and the predictive value of bilateral carotid high-risk plaques for ischemic stroke, a proposal of thesis. I will use the following 4 parts to introduce. Previous studies have shown that carotid high-risk atherosclerotic plaque is one of the major sources of ischemic stroke, and the research work of our group is mainly focusing on the atherosclerosis MR imaging. Interestingly, in clinical practice, we found that some patients have bilateral carotid high-risk plaques, and here is a typical case. The imagings from a 73-year-old male patient with bilateral carotid high-risk plaques and acute cerebral infarction in right hemisphere. From these imagings, we can see that there is T1 high signal intensity, which represents IPH on both sides. Based on the discovery, I had a discussion with my mentor. Although previous studies have confirmed that high-risk plaques were associated with increased risk of cerebrovascular events, not all high-risk plaques lead to ischemic stroke. Therefore, we can try to identify the differences of high-risk plaque between symptomatic and asymptomatic sites in patients with bilateral high-risk plaques. My mentor also thinks that is an interesting idea, but he suggested to make a literature review first. There are some studies comparing carotid plaques between the symptomatic sites and the asymptomatic sites to get some sense. At the suggestion of my mentor, I reviewed the relevant literature, which shows that the plaques on the symptomatic sites were different from those on the asymptomatic sites. Investigators have found that in patients with bilateral IPH, the symptomatic side shows stronger T1 signals, so we hypothesize that the characteristics of symptomatic high-risk plaques might be different from asymptomatic ones in patients with bilateral high-risk plaques. And my mentor thinks about that, we can also raise another clinical question. What are the specific risk factors for bilateral high-risk plaques formation? If patients with bilateral high-risk plaques have different risk factors from those with unilateral high-risk plaques. After the mentor's guidance and literature review, we hypothesized that the risk factors in patients with bilateral high-risk plaques may be different from those with unilateral high-risk plaque and those without high-risk plaque. Considerable evidence indicates that imaging biomarkers of high-risk plaques are strongly associated with future stroke, so we hypothesize that patients with bilateral high-risk plaques may have higher risk of developing ischemic stroke compared to those with unilateral high-risk plaque or without high-risk plaque. However, my mentor told me that a prospective follow-up study is suggested to determine the predictive value of bilateral high-risk plaque for future ischemic stroke. With the help of my mentor, we determined the study objectives. Before the study began, I discussed with my mentor. I'm wondering whether we can perform this study based on the existing data of CARE2 study, which aimed to determine the prevalence of high-risk plaque in symptomatic patients with carotid plaque. However, my mentor told me that CARE2 study is a cross-sectional multi-center study, which couldn't be used to investigate the predictive value of high-risk plaques for future vascular events. It is suggested to recruit new patients for the prospective study. In addition, my mentor helped me solve the confusion of sample size calculation. Patients were recruited from CARE2 study for M1 and M2. Patients were prospectively recruited and followed up to determine the recurrence of cerebrovascular events for M3. The inclusion and exclusion criteria are shown in this slide, and the endpoint of M3 is recurrence of cerebrovascular events during 1 year follow-up. All patients underwent MRI on a 30-MR scanner with 8-channel phase A coil. The imaging sequences and parameters are detailed in the tables. 2 experienced radiologists independently analyzed the MR imagings using Cascade. This slide also shows statistical analysis in detail. Before the statistical analysis, my mentor helped me to correct the mistake in the statistical methods. And my mentor reminded me that I need to calculate the sample size of prospective study, and the loss follow-up need to be considered. Of 1,047 patients of Carotid study, 43 patients who had bilateral carotid high-risk plaques were included in the first part of our study. The results on comparison of morphological characteristics of bilateral high-risk plaques are shown in this table. Compared with asymptomatic plaques, symptomatic ones showed smaller lumen area, total vessel area, and greater mosaic were indexed. Other measurements didn't significantly differ between two sites. For the qualitative analysis, symptomatic plaques have higher prevalence of juxtaluminal IPH and or thrombus compared to asymptomatic plaques, and fibrous cap rupture was found more frequently in symptomatic plaques. In the second part of our study, a total of 555 patients were included. Compared to controls, bilateral high-risk plaques patients are more likely older, male, and showed greater BMI, lower diastolic blood pressure, and more antihypertensive therapy, statin therapy. The level of total cholesterol and the low-density lipoprotein of bilateral high-risk plaques patients was significantly lower than that of unilateral high-risk plaque patients and controls. Our research group have certain advantages in both MR imaging technology and case collection, which can ensure the smooth progress of the study, but we also face many challenges. First, the sample size of patients with bilateral high-risk plaques is small. Second, in investigation of clinical risk factors of bilateral high-risk plaques, the sample size and the age distribution of each group are heterogeneous. And next, a prospective follow-up study is needed to determine the predictive value of bilateral high-risk plaques for future ischemic stroke. That's all of my presentation. Thank you for your attention.